We're going to take a look at this document, if you're ready, Corey.
I am. I've got it open in front of me here. Yep.
Okay. So it's called Access to Prescribed Safer Supply in British Colombia Policy Direction. This was published July 15th of last year from the Ministry of Mental Health and Addictions and the Ministry of Health. My general take on it is that I think they've done a really good job of using the right language. The only thing I don't like is the safer supply. I don't like the extra R on there because it's a toe in the they're just keeping the one toe on the other line there. They don't want to endorse using drugs of any kind. Even though we understand fully that pharmaceuticals are a risk versus benefit situation, this is this is kind of what we need to talk about if we're going to talk about it in a mature scientific fashion. They petitioned the federal government for some sort of an allowance. And it's my understanding that it was back in when this crisis began, they asked the federal government to allow some kind of leeway. So they would have to make a hole sort of not a hole, but they'd have to make an adjustment or an amendment to our drug scheduling to make this possible. The federal government said they didn't want to do that because it's, I guess, a tremendous amount of work, a bunch of legal stuff that has to happen, and it's. I have no idea why that's difficult, but so they gave them an emergency allowance, which instead of being a model where it would be more of a commercial setup where you'd walk into a dispensary of some sort and there'd be a clerk with some knowledge, basically like what a cannabis store is now. This is what I believe to be the general idea that most people are looking for as the one that would actually help kind of solve the problem. Because a lot of people, especially in the lower mainland, thinking about people who use drugs on the downtown east side, there's a lot of, or maybe Indigenous people, First Nations people who've had issues with police or issues with, kind of a constant patronizing top-down sort of hierarchy in our medical system. So the idea was to kind of get this access set up with as low of a barrier as possible and make the whole thing not traumatizing if possible as well.
Yeah.
Well, actually giving the person. So my idea of, I'll ask you, Corey, what would your idea be of a ideal safe supply scenario
For prescribing, or just in terms of the full sort of front to back of care?
Well, would you set it up like the allowance that they've got now has it so that doctors must prescribe? It's still a prescription.
Yeah.
There's obvious problems, liabilities, ethical issues with, doctors for the last, 7 years, they've been taking a beating with the ministry telling them that they don't want opiates. They want everybody prescribed off opiates and benzos because of the sort of pendulum swing away from the OxyContin crisis. So now they're getting this memo that says, oh, by the way, can you prescribe heroin and methamphetamines? And I mean, this first part is it's more focused on like the fentanyl problem.
Yeah.
They don't know what to do with stimulants. And honestly, it is a hell of a it's a tough one. When I look at it, I think that, I understand how the federal government or anybody could see this as something that requires a doctor. But if you're trying to do it in the most efficient, low barrier to access way, it would be just a store. Because if it's anything less than what that person uses normally, it's not real safe supply.
Correct.
If they use 3 grams of whatever, maybe they prefer fentanyl, then it's got to be fentanyl. Maybe they shoot it. Then it's got to be enough for, if they want a week's worth, so they don't have to come back every day, give them a week's worth of injectable fentanyl at the dose that they normally take. That would be, in my opinion, the way that this works best.
Yeah. Anything less than that, and it will drive people to go back and continue to get it from the streets where it is not safe.
I also believe that our health ministers are aware of that, but this is the best they could do given the parameters that the federal government will allow. And I mean, this is kind of a big, if this is to work, if this is to get through, this would be a monumental progression in drug policy. What do you think? Is this, are they going to get there with this document in this way? Is this a good enough kind of allowance here from the federal government?
I guess, and you and I were talking the other day or earlier about comparing it even more so to cannabis, that it is probably just the starting point. It's certainly not the perfected endpoint of this process. There's a point in the document that says that physicians will have the choice about prescribing. So if they're not comfortable with it, if they're not interested in making that a part of their practice, they don't have to do it. That said, I would imagine that there will be an appetite or an openness, a willingness in our province for physicians, at least some within each region, to be willing to do it.
I can verify that. Yes, it does appear.
There will probably be exceptions, but
yeah.
But I would imagine that won't be a problem.
It appears to be. It's definitely a minority of physicians.
Yeah.
But they are out there. They're willing to do this. And one of the things they don't talk about in here is what your liability insurance would be. I mean, people don't realize, I guess, that all healthcare professionals are required to have some kind of liability insurance. If you need 10 million of insurance just to practice, then a lot of physicians will maybe think, well, is the government going to pay for that? Like, who's, it's an issue that's going to have to be dealt with. And as a pharmacist, I can tell you, like, they want to get as much data as they can out of this program if it moves forward, that's smart. It's totally understandable. But the way that they want to do that is through like normal pharmacy dispensary methods. So that means there's going to have to be a certain amount of information that the patient provides about themselves. There's going to be a record of their drug use on PharmaNet. And I guess what they're going to do, it says in here, they're going to set up some products that are paid for and other products that are special authority. And I can't tell you how much of a pain in the ass that would be in this situation. Like,
can you clarify for those who don't know what PharmaNet is?
So in BC, we have a computer program, or a network, I guess it is, that every prescription that goes through a pharmacy is recorded in this cloud-based program. And it records all that data, patient notes, all your details as far as phone number, contact, where you live, age, and all that kind of stuff, significant medical conditions, allergies, you name it. In BC, we have a kind of a complicated healthcare program. We do a good job at paying for lots of medications for people who need the medications paid for. It's just complicated to the point of it being a hindrance. And I'm saying that in the nicest possible way.
Yeah. So the document says that PharmaCare will cover the costs of safer supply for eligible BC residents.
Yes. Multiple problems in that sentence.
Tell me.
Eligible is the big, they've left this one kind of open, right? Open to interpretation. And I think it's the same with the physicians. It's basically, if you feel like you want to do it, right? Because there's no guidelines, there's no protocols. That's what the whole thing is about, is trying to bring those in. So because you're breaking new territory, it's kind of the same for patient eligibility. But I don't think, it's fine the way they've put eligibility in this document, in that I think it can be interpreted as anybody who needs it, which is fine. But because they've decided to cover these products, and I guess I really don't understand why they would do that. I mean, maybe they think that it'll cut down on like petty crime.
Mm-hmm.
I'm not sure, but what it will do is it will slow down the process to make it. I don't know. I can't imagine, because you're going to have to. These are people who, they probably have lots of people who are going to use this program. They either have had trouble at pharmacies, or they don't have a home address, or it's going to be, the documentation could be a problem alone.
Mm-hmm.
And now you're, if you're asking eligibility and you're going to track how much this person is using, that means, there's assuming they're going to put limits on some things. Like that's how they do special authority. They might say you have diabetes and you have to get covered for diabetes supplies in BC, you have to go see a diabetic nurse and get educated with all the materials. And once you present that, kind of card that you've been educated, it goes on to PharmaNet. And then when you go to a pharmacy, those medications get covered. This would be the same type of idea for the medications that are special authority. Who is making that call? Like, and that's not, there's also issues with income too. And because there's going to be people who have high incomes, and they're going to come in there and they are going to have to pay, I can't imagine that most of the things they'll need here, like Hydromorph, is cheap. All these things should be fairly cheap, actually.
I wanted to ask you this point, and this fits right in with what you're saying here. Tapering or transitioning if a patient is not taking or benefiting from use of prescribed safer supplied medication. So that's pretty subjective. Like if they're not if they're not taking or benefiting, then there will be tapering or transitioning. So saying for the obvious one is like you go back and say, hey, this isn't enough. This isn't cutting it for me. Would they look at things like a patch or like something long acting? Is that what they mean?
It's difficult to say what they mean. If this is real, if this is a safe supply that it appears to be, as far as the language they're using is concerned, that means that every attempt is going to be made to listen to that, to the individual who comes in, the person who's using drugs to come in. It's not we're going to tell you what's going to happen. They're going to come in and they're going to say, this is what's going on. Mm-hmm. So there needs to be a bridge of trust there. This is how much I'm using, and this is the form I'm using it in. Can you help me? So the starting point should be, absolutely. Let's provide those items for you as long as we can. And, if they're open to, you can ask, do you need any overdose equipment? Do you have needles? You could top up on harm reduction stuff at the same time. But I mean, I can't imagine a patient that's going to come in and say, yes, thank you. You've given me pharmaceutical grade fentanyl instead of the shit that was killing me and my friends, and it's not working for me. Like, I don't understand the circumstances really there.
No, I'm not sure that I do either. And I guess, unless we're talking about tolerance, if you're,
what's the difference? I mean, if the goal of this model is to save lives, so if you cut a person off at a certain, if there's some kind of limit that they're going to decide is too much for somebody to have, well, then you know what's going to happen.
Yeah.
So to have somebody started on a program like this and then kicked off at a limit would be like a death sentence. But
so the other point right after that is patient-centered procedures and processes to prevent displacement. For example, the receipt and use of medication by individuals who were not prescribed them, for when displacement is suspected or confirmed.
Yeah, see, this is another problem. there's quite a few of these residual hangups, and they're just going to have to get over it. People are going to use, like, look, right now, I have old couples who come into the pharmacy and they're on the same medication because over the years they just trade. You go to old folks' home, it's like a flea market for drugs in there. They're trading Ramipril for losartan, and like, people don't always take their medication as directed. Okay, circumstances like this, maybe that person who gets the safe supply goes out and finds they've got a friend who's withdrawing, and all they have as an option is shitty drugs, and they're like, hey, you know what, I'm pretty topped up here, take some of mine. So you're going to punish that person by limiting them from the program? Come on, can't do it.
No, to me that sentence reads of fear of the unknown and keeping one, like you said, keeping one toe back. There's no, like you said, there's no, that is not something that can be controlled.
No.
Whether or not someone is going to share or use someone else's prescription or whatever. Once they walk out of the pharmacy, anyone, it's out of their hands.
Yeah. And that, I think it's, when I look at this as a possible model where an individual would walk in and pay for whatever the medication is, no questions asked. Like, I want 3 vials of hydromorph. This is what it costs. It's pretty cheap. They're going to be paying for something anyway. Another benefit of this model is to destroy the black market, right? You want these people who are putting those types of the lethal crap out on the streets, you want them to wither. So you're missing an opportunity, I think, by setting it up like this. But again, this may be the only option they have, given I don't know what kind of negotiations went on with the federal government. And compared to, like you said, I mean, the Liberals compared to the NDP is kind of like a blue versus red situation, right?
It says also in the policy that people with lived experience will be a part of all of the decision making along the way, and I just think that there will be tough conversations there, and there will be meetings that, as this goes on, and the program has to adapt and kind of reorganize itself, that will be really challenging.
Like, when I first read this document, I was chuckling a little bit, just because of, like, the wording that they're using is excellent, but the message is not, it doesn't line up with the type of language they're using. Like, the language they're using says this is going to be a patient focused. It should even be called a person who used drug focused program. We get the information, we learn from them, not the other way around. This is an opportunity for healthcare professionals to understand ways to really help people who are in a situation where, if they're dependent on street drugs, then they're risking their life every single day. So, that should be the most important kind of priority. The rest of the stuff, the language, the whether or not there's going to be people with lived experience, and these are all kind of, to me, they're pet words, right? And if they don't put them in there, then I mean, it's politics, I guess.
What would you say to someone who asks the question, and this is kind of, we know for a fact that there are people with this who will be asking this question, people with this mentality that if you made it available without a prescription, that anyone could walk in, then you're gonna see half the population hooked and high on opiates. What would you say to that person?
Well, I mean, I haven't seen all the evidence in the world, and I haven't read every paper and every study, and the evidence is scant in this area. most of the stuff tends to be, you don't get funded unless you're coming up with negative studies when it comes to these types of drugs, right?
Mm-hmm.
But what appears like we can look at, we do have some experience with cannabis, and that fear was there too.
Yes, it was.
And what ended up happening is, I still find this amazing, but there was more people, slightly more people tried marijuana. So there was kind of an opening up of it as an option. And these were people that the only reason they didn't try it was because it was illegal, which is, that just boggles my mind. Like, I can't, you're like, I would love to try some cannabis, but gosh darn it, it's illegal. So I won't. Like, that is like, I want to meet that person and be like, what in the hell? But everybody's got their lines in the sand.
Sure.
So what happened is those people experimented with it. Mm-hmm. Most of them didn't become, the vast majority of them maybe didn't become chronic users. And who knows, like, I didn't see any tracking that demonstrated that they were even recreational users for very long after. I think there was a 1% shift, and there was an actual decline with underage cannabis users. So nothing changed dramatically, but I would take that as an overall, like, the evidence does seem to suggest that cannabis smoking at a young age can exacerbate some mental health conditions. And that we know now with the way the brain develops that it's, if you can avoid it, it's better. It's not the end of the world if you don't, but less kids smoking cannabis is better. It's just speculation after that, really. Like cigarettes, you can go buy cigarettes. Those are just as addictive or more addictive than any of these other products that you'd be
for sure.
Forming an addiction to a drug takes a little bit of time. It's not a one-time thing, and it's you totally lose control of your life. That's not how it works. Given the state of the world, I mean, this is another thing to calculate into the whole equation. Is this is a very strange time for people to have access to drugs like opiates on a massive scale that instantly solve your your anxiety about the state of the world. And then you're into an ethics dilemma. So what? 60-year-old woman lives in a constant state of anxiety. She's watching CNN all day long. She can't turn off the TV. She barely sleeps. All the pharmaceutical meds that she takes are kind of, keeping her somewhat sane, but mostly she's losing it. Finally, she decides to go in and try some hydromorph. She has a couple capsules of hydromorph, and all of a sudden her life improves dramatically. Is that bad? I don't know. I don't think that's bad.
No.
So, I think it's a situation where you're wading into waters where there's, politically, medically, legally, there's just so many unknowns. You're not going to be able to form a document, a policy directive, or any kind of guidelines until you start doing some pilots.
We talked about it before on the podcast that it was so revealing when the pandemic hit and everything got shut down. It was not even negotiable that liquor stores would remain open. It was just like a given that they were essential. And we've talked about really looking at liquor stores as a source of safe supply. Certainly, the presence and the accessibility to liquor stores does not create more alcoholics out of people who aren't inclined to drink in the first place because they're there.
Yeah, that does not seem to be the case. And it's where I do start to wonder is I've been curious about stimulants like methamphetamine, especially. I don't know, because from what I understand, there's different kind of tiers of users in as far as meth goes. There's, rich kids who have access to 99.99% little statues of pure meth that they, take a razor blade and just carve off a little bit and then either snort it or smoke it. That's their thing. They do it once, they want to go on a bender in Vegas. They'll be awake for 3 days. That's a type of user. Then there's, the socioeconomically depressed areas where everybody's using meth because their life sucks and it's horrible quality and you don't know what's in it and it's probably made in some guy's basement. And I guess you could look at it and say it's not very hard to find meth right now anyway. Like if you wanted to try meth, like I think I would have to drive 5 minutes and it would take me maybe 10 minutes. And I've never bought meth before. And I sort of look like a cop right now, but I could still do it. Right.
Yeah,
so,
for sure.
So the question would be if people knew it was a safe product and it had that government stamp of, it went through some sort of process that, meant it was rigorously tested, would that change people's idea? I can't imagine that it would, but with that one, you don't know.
I coming back to kind of the question that you asked me at the beginning, I think I come around to it being at least a time where someone has access to healthcare. That may be the only time that someone sees a doctor, within a month or within a week. And if they are able to, if it is a clinic or a setup that is run, that is holistic, where they can see a doctor and see a nurse practitioner and have some other services at the same time, and maybe get linked up with other things that they may need, that could be a really good thing. It could be a really, really cool thing. And again, it could be the only time someone is going to cross paths with a healthcare professional, and it will be again, hopefully, ideally, a trust building experience.
Absolutely.
And without that, then we're worse off. We're absolutely worse off. And as a time for the province and the medical community and the community of people who are using drugs to get used to what this is going to be like. And then, like you said, maybe like cannabis, the healthcare system backs off and says, okay, we're not needed here. This can get on better without us. That may be so.
Yeah. Yeah. So I guess I think if you're a person who uses drugs and you're at risk of, you're using some kind of a drug that's not being tested and you're kind of rolling the dice every day. I think there needs to be some understanding that these processes are not easy from a legal standpoint. It's not easy to get healthcare professionals on board, and that is what's required under these circumstances. So for a starting point, you talk about building trust. I think if this model is going to move forward, it's a big opportunity to stop, to make sure that there's not people in there. We don't want healthcare professionals who are going to be in there who are going to take that, top down, patriarchal, you're less than me, that kind of stance. Cannot be. It must be a non-judgmental, safe. You don't want to see judgment. You want to just, how are you doing today? What can we do for you? Basically, and over time, I think there's a big opportunity to build relationships that could teach this province a tremendous amount about, different ways that this could be tackled down the road. This is kind of like this is an opportunity to open doors and also save a bunch of lives.
Yeah. And I think the length of time that this has gone on without a big step like this, without a big move towards creating a safer circumstance for anyone who's using drugs. That in itself, that length of time that has passed, and that horrific death toll that has accumulated, has damaged that trust and damaged the relationship.
Yeah, I mean, it was already. I mean, it's a bad relationship to start, and each passing day, every coroner's report, every now we're into 5 digits. We don't want to see this thing hit 6 digits.
No.
We don't want to see that. Every single one of these deaths is a death that is going to not only affects us now, it affects our communities, their families, friends, and it ripples outwards into the whole province. But these deaths they'll be affecting us for years to come because it's hollowing us out. These are taking people that are not retirement age. There's, it's taking people who are like 20 to 49, basically. That's the majority of it.
Yeah, I've got the August statistics in front of me here from BC. 169 deaths from illicit drugs in August, and 71% were age 30 to 59.
Yeah.
71%. Yeah.
Yeah, and that's your, if you want to look at it like a cold-hearted business person, that starts to affect your GDP.
Yeah.
I mean, you're losing a lot of people who are, could have a job somewhere and could be producing products. The total health costs of opioid use in BC, so it's just opioids, are estimated to exceed 90 million annually, and the economic cost of lost productivity associated with opioid use is close to 1 billion a year. So, what do we spend to run our healthcare system in BC? What is it now? Like 10 billion? I forget. It's always going up. I'll have to check on that. Maybe it's 1 trillion. But 1 billion a year, that's a lot of money for BC. Yeah, we'll see, I guess. I don't think that it's a problem that's going to get rushed by an economic factor.
No.
But there are certainly, there's going to be people who are looking at that and scratching their heads. Like there's no indication as to what drugs would be provided other than they say it'll be started with opioids, and then they don't know what to do with stimulants yet. So they're going to kind of go opioids first, see how it goes. And then, so I'm guessing that means no cocaine either.
I have not seen cocaine listed on this document. I was looking for it, and because the number of overdose, and I haven't seen that statistic either about the number of overdoses related to, or accidental overdoses related to cocaine use when they're not even aware that they're taking an opiate in the first place.
Yeah. I lost a friend's father, just a recreational user, and got a hold of some cocaine that had fentanyl in it. Opioid naive, gone.
Yeah.
And I don't know how those get counted. Would they count that as an illicit opioid death?
I think they would. Like, at least I'm recalling scenarios that I encountered when I was a nurse, where it was certainly called an opioid overdose that didn't line up with what the friends or the people that were with the individual were saying. Like, we were just partying, we were having some drinks, he did what we thought was a little bit of coke, kind of a thing. And I remember situations like that were, but it gets called an opioid overdose.
Yeah, I did some digging probably about a year ago to try and see if I could parse out if the Stats Canada was keeping track of opioids versus cocaine deaths or stimulant deaths or whatever, and I couldn't really. I couldn't find any information that was useful, so I don't know if that's a lack of data mining ability on my part, or if that's because it's just not available. You would think, though, that it would be beneficial to, not you want those numbers as clear as possible. And if it's lots of them are going to be polysubstance. So if they're polysubstance, great.
Yeah.
Put all those down, and that's a category. Even with these adulterants, say exactly what was in there, and then mark that down and keep all that information so that you can, kind of track where this is going. Yeah, I don't know, but you got to start somewhere. I mean,
and I think I applaud BC for being in the position where we're at right now, and I hope that it sets an example for other places across Canada, because it's certainly not just here that needs this.
Yeah, you're right about that, and I think this would be such a historical progression, not just in North America, but in the world. I mean, BC would really, come back as far as a progressive part of the world if we were able to pull this off.
Yeah.
And track it properly. And, I think it could be done.